Thank you very much for the invitation to give this webinar. So the topic would be the use of SGLT2 inhibitors in treatment and reducing the risk of cardiovascular events and heart failure. We do know that, that patients with heart failure are at very high risk for mortality, and it carries a very high risk for dying. If you look at the values here, it is that most, for example, in men, heart failure actually carries a higher risk for mortality than prostate cancer, and in women, even a higher risk for breast cancer. So heart failure is certainly a malignant condition and not as benign as most people think. And despite therapy, we do see that mortality and morbidity is still increased. So if you look at the incidence of and the prevalence of heart failure, and this is just UK figures, there's been in the past couple of years, let's say from 2002 to 2014, about a 12% increase in the number of new heart failure diagnoses, and about a 23% increase in the number of people living with heart failure. And despite modern medication or medicine for the treatment of heart failure, the improvements in heart failure survival have really been modest. So if you look at 1-year survival rates, there was about a 6.6% increase. 5-year survival, about 7.2% increase, in 10-year survival, about a 6.4% increase. So we're not doing that great, actually. And we know that people that needs hospitalization for heart failure have a worse outcome. And it's because these people are sicker. So if you look at median survival, patients without heart failure, survival is much better if they're not hospitalized. But if you are hospitalized for heart failure, not admitted to hospital, your median survival is about 5.3 years. But after you've been admitted, the survival rate decreases to about 3 years. And if you look at mortality rates following the first hospitalization for heart failure, you can see the 2-year mortality rate is about 40%. So again, if people get hospitalized for heart failure, it clearly is evidence that your outcome is worse. Just looking at diabetes, diabetes is one of the 2 major risk factors for the development of heart failure. And that second, for example, after myocardial infarction and other causes, of course, hypertension and valvular disease, but diabetes per se carries a high risk for development of heart failure. But we also see that type 2 diabetes and heart failure often coexists. If you look at type 2 diabetes trials, the heart failure prevalence is between 10 and 30%. And if you look at heart failure trials, the type 2 prevalence, or the prevalence of type 2 diabetes in these patients is about 30%. So they often coexist. So heart failure and left ventricular dysfunction are early and often undetected complications of type 2 diabetes. And not only systolic dysfunction, but also diastolic dysfunction. So about 68% of patients had evidence of asymptomatic left ventricular dysfunction after about 5 years after diagnosis of type 2 diabetes. And undiagnosed heart failure was detected about 28% of patients with diabetes during routine cardiac screening, of which most will have, interestingly enough, heart failure with preserved ejection fraction, which, as you will learn later, is extremely difficult to manage. And we don't have the answer yet in the management of these patients, but it seems that the SGLT2 inhibitors is giving us some hope. So again, type 2 diabetes does increase the risk of developing heart failure symptoms in this group of patients. And so diabetes increases your risk of hospitalization for heart failure. And despite control of the known risk factors, that is hypertension and hypercholesterolemia, we do see an increased risk of developing heart failure in our patients with type 2 diabetes, and that is irrespective of other risk factors being under control. And it seems that there is an atherosclerotic mediated mechanism and a non-atherosclerotic mediated mechanism for the development of heart failure. And we think that the atherosclerotic independent causes of heart failure includes direct inflammatory effects on the microvascular endothelium and the myocardium, with subsequent fibrosis leading to the stiff ventricles with diastolic dysfunction. So again, as I've mentioned, hospitalization for heart failure is associated with a very much more worse outcome and poor prognosis, and that needs to be prevented at all costs. And the more you get admitted for heart failure, the worse your outcomes seems to be. So if you look at this Kaplan-Meier graphs and number of hospital admissions here at the bottom, the more admissions you have for heart failure, the worse your prognosis becomes. Now, just looking at previous trials for diabetic treatment and the risk of complications. Now, what was interesting, it doesn't seem that intensive glycemic control resulted in reduction of heart failure. So we know that diabetes carries a very high risk for development of heart failure and heart failure hospitalizations. But looking at the previous trials that was done for diabetic control, what was evident is that even if you control these patients very aggressively, you get the hemoglobin A1Cs down, the risk of heart failure and heart failure hospitalizations didn't go down. And so we clearly moved away from this glucocentric approach where we thought that treatment of diabetes is the most important thing, to choosing different drugs. And if we look at the cohorts now of the more modern type of diabetic drugs that's being used now for the treatment of diabetes, and just standing still to the DPP-4s, it actually shows that the DPP-4s made no difference in the risk of hospitalization for heart failure. And actually, if you look at saxagliptin, the risk was actually increased for hospitalizations for heart failure. Looking at the GLP-1s, again, I mean, we do know that the GLP-1s reduces your risk for cardiovascular events and myocardial infarctions. If you look at the LEADER trial, which is the most well-known trial, there was clearly a reduction in cardiovascular events, but it made no difference in hospitalization for heart failure in our patients with diabetes. And if you look at the glutazones, the pioglitazone actually increased your risk for developing heart failure. So these drugs should be very carefully used in patients who has a history of either heart failure or previous myocardial infarct with reduced LV function. So the glutazones actually has worse outcomes in heart failure in our patients with type 2 diabetes. So then the SGLT2 inhibitors came along, and there was, I just want to stand still with 3 outcome trials that was done. And the EMPA-REG that was done with empagliflozin, CANVAS with canafilgosin, and DECLARE, which was done with DAPA. Just to explain the differences between the 3 trials, the EMPA-REG outcome was all a second prevention trial. That's to say patients with already cardiovascular disease, coronary artery disease, and peripheral vascular disease. Whereas the DECLARE that was done with DAPA was mostly a primary prevention trial. So these patients had risk factors for ischemic heart disease, but only 40% of them had established cardiovascular disease. The GFRs was a bit better in the DECLARE trial, a little bit worse in the EMPA-REG outcome trial. So the DECLARE trial had the largest portion of patients with type 2 diabetes with cardiovascular risk factors only, but not documented cardiovascular disease. Only 40% had documented cardiovascular disease. So primary prevention would then mean people who had risk factors already had atherosclerosis, but when they had the infarct, then these patients moved over to the secondary prevention arm with already ventricular dilatation, patients with congestive heart failure or end-stage heart disease. So the DECLARE trial had 2 groups of patients. So either had had to have, or they were more than 50 years of age with more than 2 risk factors. And those were the primary prevention group, or they had to be more than 40 years of age with established atherosclerotic cardiovascular disease. So this was about the 40% group of people. They had well-preserved GFRs, and these were the patients that we included in the DECLARE trial. And there it was clearly shown that dapagliflozin, although there was a tendency to reduction in MACE, and I'll just go back to that in a slide or two later on, but there was a clear reduction in the hospitalization for heart failure and cardiovascular death in the patients that was given dapagliflozin 10 milligrams. What was also interesting is that it showed that these group of drugs was clearly renoprotective. So using DAPA 10 milligram, there was the composite endpoint of an eGFR decreased by more than 40%, or end-stage renal disease or renal death was substantially reduced in this group of patients. So if we now just look at the summary of the DECLARE TIMI trial, MACE was reduced by 7%, although it was not statistically significant. But hospitalization for heart failure was reduced by 27%. Cardiovascular death and hospitalization for heart failure, if you look at the composite endpoint, was reduced by 17%, and renal outcome was reduced by 27%. And that is, and I will show you later on, very important in the treatment of our patients with heart failure as well. So if we just look at now, this actually summarizes it very well. So the primary prevention group, patients that had risk factors but did not have established cardiovascular disease, there was not a reduction in MACE. But if you look at that 40% group of patients where they had, let's say, prior MI less than 2 years ago, there was a reduction in MACE, and the numbers needed to treat here was only 38. But what was very important is that his hospitalization, or the chances of being hospitalized for heart failure, was significantly reduced, and here the numbers needed to treat was only 53. So this also held true for the other outcome trials for the SGLT2. So looking at the EMPA-REC, for example, that was done with empagliflozin, and CANVAS, that was done with CANA, clearly showed a reduction in MACE. It showed a reduction in cardiovascular death and hospitalization for heart failure. In all 3 drugs, in all 3 trials, chances for being hospitalized for heart failure were significantly reduced if that was compared to placebo. Another interesting point is that we do know that these drugs do need a rather preserved renal function to work for diabetes. But if you look at heart failure, it actually showed that your kidney function can be poor, and even in these patients it worked. So if you look at especially the EMPA trial, it actually showed that hospitalization for heart failure and cardiovascular death was also significant, even in moderate reduction or moderately reduced renal impairment, also in the mild and in normal. It also cardiovascular death and heart failure hospitalization. So it doesn't really matter if your renal function is impaired. It seems that the SGLT2s also has an important impact in heart failure prevention in patients with reduced LV or with reduced renal function. So if we now look at all the trials done with the SGLT2s, we now, from these trials that I've just shown you, the outcome trials clearly showed that patients with diabetes with cardiovascular risk, the CANVAS and DECLARE, showed benefit. Diabetes with established coronary artery disease showed an improved outcome. And then I haven't shown you this, but patients with proteinuria and renal disease, the Credence trial clearly showed benefit. But what about patients that are non-diabetic? That's to say patients without diabetes, but with established heart failure. Would these diabetic drugs work for these patients as well? And there was a couple of trials that was recently published, and I just want to stand still on the DAPA-HF trial. The DELIVER trial will be published within the next couple of months, and the Emperor Preserve trial was actually presented now a few months ago, and I'm just going to show one or two slides on that. So what about patients that are non-diabetic? So patients with heart failure, but they don't have diabetes. Will these drugs be effective in the management of their heart failure as well? So the DAPA-HF trial was then published in November 2019, where they looked at dapagliflozin in patients with heart failure and reduced ejection fraction. And these group of patients included diabetics and non-diabetics. So these patients had to have New York Heart Association class 2, 3, or 4. They had to have ejection fraction of less than 40%. It included almost 5,000 patients, and they were given dapagliflozin 10 milligrams or placebo. The primary outcome of this trial was then a composite of worsening heart failure, which means hospitalization or an urgent visit resulting in intravenous therapy for heart failure or cardiovascular death. So most of these patients were in New York Heart Association class 2. They had an ejection fraction of less than 40%. The GFRs was around 60. And if you look at the treatment, the background treatment, most of them were on very good background treatment that included diuretics. It included ACE inhibitors or ARBs. They were on ARNIs. About 10% of them were on ARNIs. Beta blockers, more than 90% of them. Spironolactone, more than 70% of them were on Spiractin, and about 20% of them were on digitalis. And also, and the patients that were diabetics were on a good background of glucose lowering therapy. And what was actually significant is that DAPA significantly reduced the relative risk of cardiovascular outcome or worsening heart failure on top of standard therapy by about 26%, with numbers needed to treat being only 21, which was quite significant. And what was also very significant is that the primary endpoint was statistically significant already as early as day 28. So you can see that the curves split actually very early, and you already reached statistically significant difference by around day 28. So if you look at the difference in outcomes, the primary outcome, which was a composite endpoint, was significantly better in the patients receiving DAPA. And that was mostly made up by the hospitalization for heart failure. If you look at all-cause mortality and death from cardiovascular cause, it didn't reach statistically significant. So most of the benefit was from reduction in hospitalization for heart failure. If you look at the changes in proBNP, that was clearly reduced in patients getting the active agent, that was DAPA. And what came out in this trial, it didn't make a difference if you were diabetic or not. So the patients without type 2 diabetes did just as well on dapagliflozin as the diabetics did. And again, as I've mentioned earlier, even in patients with poor renal function, if you look at GFRs, even less than 60, these patients also derive benefit from history for hospitalization for heart failure, as in patients with normal kidney function. So what about hemoglobin A1C? So again, patients without type 2 diabetes, there wasn't really a reduction in hemoglobin A1C as expected, but in patients with type 2 diabetes, as it is a diabetic drug, there was an improved hemoglobin A1C. What was also very interesting is that hematocrit levels was increased in these group of patients. We do know that patients with chronic heart failure often become anemic, and that anemia in heart failure patients carries a significant increased morbidity and mortality. And the reason why it increases hematocrit is it increases erythropoietin levels. So in both the groups both type 2 diabetes and without type 2 diabetes, there was increased hematocrit levels, which also then reduces mortality. So what about safety in these patients? So in the DAPA-HF trial, it was a safe drug. So volume depletion adverse events was balanced between the two groups. Renal adverse events was actually fewer in the dapagliflozin group. As I've mentioned, it is renoprotective. Major hypoglycemia events was few and balanced between the two treatment groups. Amputations, fractures, and fourniers gangrene, there was no increased risk. And as you know, in the previous trial with canagliflozin, there was increased amputations, but in DAPA, in this trial, there wasn't increased events. DKA events, already mentioned, it can occur in this group of drugs, but in this trial it was rare, but it was a little bit more frequent in the dapagliflozin group. And then non-serious genital infections that led to drug discontinuation was a bit more, as to be expected in the dapagliflozin group because of increased glucose excretion in the urine. So in summary, if you look at just the safety profile in this group of drugs, dapagliflozin was well tolerated and the rate of treatment discontinuation was low. So after these trials were published, the new European guidelines came out. And as you can appreciate, when we treat heart failure, we often distinguish between reducing patient mortality, what drugs shall we give that reduces patients' hospitalization and mortality, and which drugs only treat symptoms. So we know treating volume overload with diuretics makes the patients feel better, so that's always on board, but it doesn't make any difference in patients' mortality. So now, if you look at what drugs one should give to reduce patients' mortality and morbidity, the SGLT2s are now on par with ACEs and ARNIs, beta blockers, and aldosterone. So if you really want to do the best for your patients with treating patients with heart failure with reduced ejection fraction, the SGLT2 should be prescribed initially in combination with your spironolactones, beta blockers, and ACEs, ARBs, or ARNIs. So what about patients with heart failure with preserved ejection fraction? This remains a huge challenge for us as clinicians, because we do know that the normal group of drugs that we use to treat patients with heart failure with reduced ejection fraction, including now the ACEs, beta blockers, do not make any difference in mortality in patients with preserved ejection fraction. We give these patients diuretics to reduce their symptoms, but we do not really impact on their mortality and morbidity. So the Emperor Preserve trial was recently discussed at the European Journal of Cardiology. And in this case, empagliflozin was used, and it was given as 10 milligrams daily comparing that to placebo. They had a mean follow-up of about 24 months. And the primary endpoint here was cardiovascular death or hospitalization for heart failure. And what was very interesting, if you look at the endpoint being hospitalization for heart failure, there was clear a benefit in the EMPA group, and that was the same for patients who recently presented with volume overload, that's to say with pulmonary edema or peripheral edema and so on, or patients with no recent volume overload. So it made a significant difference, and you can see with a highly significant p-value. And if you look at the combination of cardiovascular death or hospitalization for heart failure in patients, again, comparing that with or without recent volume overload, the empagliflozin group clearly derived a huge benefit in comparison with placebo. So it seems that with the SGLT2s, we now for the first time a group of drugs that has the potential of making a difference in the treatment of our patients with heart failure with preserved ejection fraction. So the question now remains is, how does these drugs work? I mean, it was brought out as a diabetic drug, but now it's moved, the emphasis has moved over to a cardiovascular drug. And how does it work in reducing our heart failure hospitalization? So this trial was published in 2018, which then looked at a different volume regulation hypothesis. And if you compare, in this instance now, DAPA to bumetanide, which is a loop diuretic, what is very interesting, if you just look at 24-hour sodium excretion, with DAPA, you get a much more even 24-hour sodium excretion in comparison with bumetanide. Blood volume is not so severely impacted with DAPA as with the loop diuretic, and interstitial fluid volume is much better regulated with DAPA. So it seems that the SGLT2s relative to loop diuretics reduce interstitial blood volume more than it does blood volume, which then leads to better renal perfusion and reduces the risk of developing cardiorenal syndrome, which is a huge problem for us when we treat patients with acute heart failure. Most of our patients with heart failure will present with some form of cardiorenal syndrome, which impacts on renal perfusion and renal function. And it seems that the SGLT2s are a much safer group of drugs in this scenario. So the SGLT2s, in this case DAPA, was also shown to have a very good effect on systolic blood pressure. If you look at ambulatory systolic blood pressure over 12 weeks, clearly DAPA was actually better than hydrochlorothiazide, and certainly better than placebo in reducing systolic blood pressure over 24 hours. DAPA was also shown to improve left ventricular diastolic function in patients with type 2 diabetes and heart failure. This measurement, EE prime, is a Doppler measurement that we do over the mitral valve that gives us a good indication of diastolic dysfunction. And you can see after 6 months of DAPA treatment, this value was much better. If you look at left ventricular mass index, also DAPA reduced that quite dramatically. If you look at cardiac failure biomarkers, in this instance, proBNP, I did show you in the DAPA-HF trial, proBNP was reduced. And this is canagliflozin that was clearly shown to reduce proBNP as well. And if you look at high sensitivity troponins, was also significantly reduced. As you are well aware, central nervous system activity is increased in patients with heart failure. That's why we get this tachycardia and why beta blockers work very well. So DAPA also reduces central nervous system activity quite dramatically, which is of benefit, of course, in the treatment of patients with heart failure. So in patients with heart failure, you get this renal stress, which leads to renal hypoxia, which then stimulates the afferent renal sympathetic nerves that leads to central nervous system activation and heart failure. And the SGLT2 then reduces this or inhibits renal stress hypoxia, and therefore eventually leading to reduction in central nervous system activation and improvement of heart failure symptoms. So in summary, as I've shown you, these drugs are very effective in the management of our patients with heart failure, and not only preventing hospitalization for heart failure, but also treatment of heart failure. And now it's been shown also to be of benefit in the management of patients with heart failure with preserved ejection fraction. So in summary, how does these drugs work? So there's certainly, it improves natriuresis. We've got increased osmotic diuresis. We get this inhibition of cardiac sodium hydrogen exchanger. We get modulation of cardiac autophagy and mitophagia. We get reduction in central nervous system activation. We get inhibition of cardiac calcium calmodulin 2, there's reduction in blood pressure, especially systolic blood pressure. We get improvement in vascular structure and function. I've shown you in the previous trial, there's increased hematocrit, and this is because of the increased production of erythropoietin. There's reduction in glucotoxicity. There's an increase in vascular regenerative cardiac stem cells, improvement of cardiac microvascular function. I haven't shown you this, as time doesn't allow us to, but there's a modulation of cardiac energy metabolism, which leads to increased cardiac cell ATP, and there's reduction in uric acid levels, and reduction in myocardial oxygen supply demand mismatch. And all these factors then leads to better outcome in our patients with heart failure. And I thank you very much for your attention.